Excuse me, ladies and gentlemen. Thank you for your patience in holding. We now have your presenters in conference. Please be aware each of your lines is in a listen-only mode. You may submit your questions electronically anytime using the chat pod located to the right of your webinar platform. You may also download a copy of today's slides using the files pod located below the slide presentation. It is now my pleasure to turn the conference over to today's first presenter, Chris Hunt. Please go ahead.
Thanks, Stephanie. Hi, everybody. Good morning or good afternoon, wherever you might be in the world. It's nice to see so many people joining us for the May 2020 AHA Team Training Monthly Webinar. So today we are talking about high-performance teamwork in incident management. So hopefully something that is, you'll be able to draw some definite learnings from, especially in our time right now. And thank you all, as always, for taking the time to join us. I know that these are trying times, whether you are, currently working in a healthcare scenario or if you're working from home. They're trying times in different ways. So I really appreciate you taking the time to join us for this hour, and hopefully it brings something useful to you and also provides a little bit of normalcy in your day. My name is Chris Hunt, Senior Director with the Center for Health Innovation at the American Hospital Association. All right, just some rules of engagement today. The audio for the webinar can be accessed in two separate ways. So you can listen to it through your phone, and if you do that, you want to mute your computer speakers, because what happens is you get that weird echoey effect. Or if you have a really solid internet connection, you're more than welcome to listen through your computer. So there's two different ways you could do it. If you have trouble with audio, it's always great just to dial in on that phone number to get to hear it, obviously. All hyperlinks on the screen are active. If you click them, they won't take you out of the webinar. They'll just open up another screen. So if there's something we're going through and you're interested in it, click on that hyperlink, save it for later. The way we do Q&A is that we have a Q&A session at the end of the presentation. We'd like you to write questions in the chat box that you see on your screen that you're using right now as we go. And I'll kind of collect those and turn them into a Q&A session that hopefully follows a nice logical narrative. And if there's anything that we don't get to, we'll have an opportunity for you to get your questions answered in the future. So those are our rules of engagement. Continuing education credit. All right, so we partner with Duke University to provide you with this free hour of CE credit for you. In order to qualify, you must have an active Duke OneLink account and watch this webinar live. If you do not have a Duke OneLink account, please download the Continuing Education Instructions PDF in the Files pod in the lower left part of your screen in order to set up your account and confirm your mobile number. This is a one-time setup, so you may use your account for all future AHA team training webinars, or if you've already done this for a previous webinar, you'll get to use it from that. We'll share this again at the end of the webinar, but the way you get your credit is you must text the letters TARWOR to the number you see on the screen within 24 hours of this live webinar to receive credit. And that's the really important part here, is that you have to do it within 24 hours of the live webinar to receive credit. All right, so upcoming events that we have, we have a webinar coming on June 17th at noon Eastern Time that is on telehealth. So it's Teams Transforming Healthcare via Telehealth. And so in this, we're going to be discussing the journey of the University of North Carolina and how they established a telehealth program, and also we'll share several case examples of how this teamwork is critical to telehealth workflows. So also very pertinent, I feel, to right now with just the explosion of telehealth and how it's interacting with teams in the past month and a half with the pandemic. I also think it's interesting that today's speaker comes from Duke University, and next month is North Carolina. So we have a nice little basketball rivalry going there in our webinars. All right, so a new announcement here is that we're proud to announce our new online, on-demand community platform to bring healthcare teams together. So this is called Mighty Network. So with the AHA Teams Training's Mighty Network, we are fostering an environment where resources and solutions can directly reach the hands of those who need it most, all of you. So our Mighty Network will allow the team training community to support, connect, and share with one another like never before. So this is like our version of a social media platform for the AHA team training community. Creating an online community is something we've always wanted to do, and you've really asked for it too. And with the world looking for more virtual connections, now's a great time for us to really get started on this. So, it's kind of hard to believe that it took a pandemic for this to get launched, but, necessity is the mother of invention. So here we are. We have this system up and ready for you. We hope you use it. So by joining AHA Team Training's Mighty Network, you'll be able to connect with your peers who share similar successes and challenges, share and request tools, content, and stories. So if there's something you're looking for, something you need, make sure that you go on and do that and ask for it. And we'll also give you access to exclusive content. So we went ahead and we've already updated the slide deck for the TeamSTEPPS Master Training course. It has a new look and feel. We've been using this for the past couple of years in our courses, but now you can download all of those slides with the new look and feel. So if you're interested in that, the only place you can find it is on Mighty Network. And Mighty Network is a free resource for you. So to make this community a thriving reality, we need your help. Every time you contribute a story, an experience, a resource, an idea, what you're really doing is building up a collective knowledge base for your fellow members. So everybody can tap into it. Like I said, it's a free resource for the community. So you can click on the link on the slide, and then we'll also have the link dropped into the chat box so that you can create a profile and start interacting today. So we're really excited about this, and we really hope that this is something that you all take advantage of. All right. So without further ado, I'm here to introduce today's presenter, Erin Eckert, who's the Education Coordinator with the Duke Center for Healthcare Safety and Quality. Like I said, we've got a nice Duke versus North Carolina thing going on here. Since we can't have real basketball, we'll at least get the two universities going in webinars. Erin has been a TeamSTEPPS Master Trainer for many years. She comes from a really interesting background that she'll be learning about today with understanding incident management, and she's been a part of our team at Duke University teaching TeamSTEPPS for a good long time. So really happy to have her here today. I think you're going to love what she has to say. So I'm tossing it over to you, Erin.
Great. Thank you so much, Chris. Welcome to everyone. Thank you so much for joining us. I really appreciate you taking the time. And like Jen and Chris have both shared either through chat or verbally, any questions you have, please feel free to enter them in the chat box. Chris will do a great job of facilitating our Q&A at the end. And any questions that don't get answered, I'm happy to help address them after the webinar. So thank you again, and we'll get started. So the objectives for the webinar, just to cover a little bit of what we'll be talking about today, is talking about the relationship between TeamSTEPPS teachable learnable skills and the principles of the National Incident Management System, or as I'll refer to it today, NIMS. Again, we'll be describing the common challenges to effective teamwork and incident management and identifying just-in-time TeamSTEPPS tools that can enhance effective communication and situational awareness in current incident management scenarios. I can't imagine what we're going to talk about in terms of incident management. It's been so long since we've had a disaster. Just kidding. We're going to talk about COVID. So what are some of the common teamwork challenges that we recognize in our healthcare environments every day, in our workplaces, in our family, and in our friends when we work together on things? Hopefully, as you're looking at this list of common teamwork challenges, you're starting to see some things that you're familiar with. You're seeing failure to use plans, failure to provide situational information, decisions not being conveyed. All of these things are the experiences we face sometimes in teamwork when it's not going as well as it should. And as you're looking at this, share in the chat box if you feel welcome or comfortable doing that. But I'm sure that you find that some of these are your frequent flyers. You see these happening routinely, not just every now and then, but they seem to continually crop up in your teamwork activities. And so be thinking about these as we're going through the webinar. For those of you who probably haven't spent as much time thinking about incident management and emergency management as I have, because that was my career for 15 years before joining healthcare, the three incidents that I have up on the screen here, clearly everyone knows September 11th. That's something that I feel pretty comfortable that everyone has some knowledge or awareness of that incident and how terrible it was that day, and for the responders in the community in New York and at the Pentagon in Virginia and Shanksville. We're still learning from that incident, and we're still trying to live up to the ideals that we have for fixing the errors that we saw in that. But only 4 years after September 11th, it's hard to imagine that it was only 4 years later, after we had done so much work to try to improve our emergency response, we had Hurricane Katrina. And that was pretty much our disciplines, what not to do in emergency management. We were watching it on TV, watching Hurricane Katrina slam into the Gulf Coast and, hoping beyond all hope that it wasn't the worst case scenario, that people would be saved and safe from that incident. But then the levees failed. And so what was a terrible incident to begin with, everyone thinking this terrible hurricane, we might have dodged it, turned into something much worse. For all the heroic rescues we saw on television and read about in the newspaper, thousands still lost their lives in the aftermath of the storm. Many of those who survived suffered in terrible conditions due to delays, confusion, and as described here on this slide and in the report describing it, the failure of initiative to aggressively meet survivors' needs. Survivors were evacuated to different cities and states, often with nothing more than the clothes on their back. Hurricane Katrina became one of the most costly and destructive disasters in history here in the United States. More than 1,800 people died as a result of that, and most of that was not during the storm. So it's been a hard lesson to learn, but we're trying. We're trying to take that and continuously move ahead. But then we had Hurricane Sandy, which challenged us in a new way. That if you're looking at that little map on the screen right there, each one of those dots that has the little white box next to it represents an incident management team that was deployed before the storm to meet the needs of the communities that would be affected by that event. And as you can see, that's a lot of dots and that's a lot of names. Each one of those teams represents somewhere between 8 and 30 highly trained incident managers who come together and function as kind of maybe a SWAT team, as you might refer to it, for managing incidents. And what we learned from Hurricane Sandy is when we have a big incident, we might not have all the people we need to run those incidents. We were running out of people. We were running out of incident management teams because of the scope of the disaster. And we certainly learned a lot of lessons from that response as well, that, it takes a lot of people, a long time to recover from something that large. These teams were deployed for weeks, if not months, and the damage to critical infrastructure throughout the region disrupted nearly every aspect of daily life for the hard-hit areas. It took a long time to get back to normal. So each of these disasters caused devastation to the communities they impacted, but those impacts were compounded and magnified by the failures in our incident management systems and failures in teamwork, both within and between response partners. So now I'm going to ask you to reflect back. Do you remember that screen that I showed you that had the common list of teamwork challenges? That initial list that I asked you to keep in the back of your mind? Would you be surprised to know that every item on that list was a paraphrased finding taken from the after-action reports and the commission reports that were researched and written after these events? So what seemed like simple teamwork errors, simple teamwork challenges that we're all familiar with were some of the major findings after these huge, massive disasters. It really came down to teamwork. And if TeamSTEPPS has taught us anything, it's understanding the teachable, learnable skills of teamwork can be applied to a lot of different situations, and that's what we're here to talk about today. So what is different about teamwork in disasters? In many ways it's similar, but in many ways it's different. The big challenge is that by definition, these disasters exceed the capabilities of any one team or organization. If you can handle it yourself using the resources you have without much stress, it's probably not a disaster. You're just responding to an incident. But when we're talking about disasters, we're talking about situations where teams must be formed quickly, and they have to begin immediately functioning as a high-performing team to gain control of that incident and prevent it from getting worse or expanding, and to meet the survivor needs. Team members may or may not know each other before the incident, and what we're learning even more is that different disciplines from different jurisdictions and authorities have to work alongside one another, either to achieve the same objective or sometimes recognizing the interdependencies between their objectives and how they need to depend on each other to get the job done. And then, of course, taking into consideration that teams are operating in really stressful, difficult situations. The phrasing they like to use is austere. That basically means you might not have communications, you probably don't have toilets, you don't have the resources you need, and you're scrambling, and you're doing the best with what you have. Our expectation in those situations is that first responders will tame that chaos and overcome all of those tremendous barriers to accomplish the amazing, the heroes. But the reality is that the groundwork for that success or failure that we see in emergency response is laid long before the incident ever occurs. You don't get a chance to make up for failures in planning when a disaster happens. So disasters have a tendency of ruining our best laid plans, but what we've learned and what we're recognizing is that the process and partnership in making those plans is what really counts. It's the act of sitting down together and talking about how we're going to work together, what practices and policies and resources and capabilities we bring to the table is what enables us to enact those plans when the time comes. So you'll see here a timeline. This is from the emergency management or incident management community. This is what our world has looked like since 2001. I still say our because I still feel pretty connected to it even though I'm in healthcare now. Starting with the September 11th attacks, you can see on the top line are the events, the really big events where we had lessons that we needed to learn and we needed to change. On the bottom, you'll see the Homeland Security Act, the Act. What happens after a disaster, especially one that doesn't go well, is that there are new requirements established and new rules and new commissions and everybody wanting to get involved to prevent another disaster like that from occurring. And so there's been a lot of change in this profession and in this world since 2001. And as you can see here, we're still dealing with these things. There's no legislation yet following Hurricanes Harvey, Irma, and Maria on this timeline, but you can be sure that it's coming, similar to the legislation that will be coming after COVID. And so as a community, it's our responsibility to continue to grow, continue to learn, and continue to adapt our understanding of how to best provide that teamwork when it's needed most. I will say that we talk about these events as disasters and examples of what not to do, but there are also, within those lessons, some examples of what we should do. Those successes have actually laid the groundwork for the improvements we've made since September 11th. On 9/11, the use of the Incident Command System, ICS, as I'll be referring to it, and mutual aid support from regional partners, both of those were fairly new practices at the time. That's what contributed to the successful response at the Pentagon site. So we compare and contrast the different ways of managing incidents, and the command structures and the policies and practices in Virginia actually led to successful response outcomes, and that's what we've been modeling a lot of our change after. And then during Katrina, although pretty widespread, an example of what not to do in the earliest stages of a response, many of you are familiar with the U.S. Coast Guard's response. They showed tremendous adaptability and ingenuity to save more than 33,000 people in the days following that event, without any serious injuries to responders or those they rescued, which is a pretty amazing consideration, especially when you realize that they didn't have communications. They were in extremely dangerous response conditions that they hadn't particularly trained for. They weren't training for landing on rooftops in urban areas. They were thinking about, out at sea or more remote areas. And most importantly, that most people don't realize is there was no air traffic control or dispatch function in place when they started flying those rescue missions. It was truly just a lot of helicopters and aircraft and boats and staff working seamlessly together to rescue those people under the worst possible conditions. And yet they were able to do it. And so we wanted to know why. And the Government Accountability Office, GAO, commissioned a study afterwards. And they noted that it was the standardization in training and roles and equipment that enabled them to perform this well. Coast Guard personnel from anywhere in the country could come together and function as a team with very little thought put into how they were going to overcome their differences. So one example is that a helicopter pilot from Florida, a co-pilot from Alabama, and a rescue swimmer from Alaska could form a crew and immediately start rescuing survivors. And that's pretty phenomenal. So these two examples that I share are basically at the heart of the culture change that we're creating in incident management. The standardization across disciplines and jurisdictions, the facilitation of mutual aid support, and adaptability to meet the needs of survivors safely and effectively. So what does this remind you of? Culture change in incident management. We always talk about culture change in healthcare. And in incident management, if you weren't a part of this before September 11th, or if you're not a part of it now, you might not realize how dramatic this shift has been. What we call pre-September 11th bears absolutely no resemblance to how things work today. And that's only 15 years, 20 years ago. So when President George Bush issued Homeland Security Presidential Directive Number 5 after 9/11, one of many presidential directives following that incident, it directed the emergency response community to enhance the ability of the U.S. to manage domestic incidents by establishing a single, comprehensive national incident management system. That's culture change. NIMS was published in 2004 and based largely on the incident command system that we talked about previously in the Pentagon response. It started in the fire service organizations in California in the 70s and had been slowly spreading to other locations. But it was really this national incident management system that led to spread of this new best practice. The system is simple and easily scalable from a single resource all the way up to large multi-agency operations. And of course, every organization was eager to adopt this new philosophy and leave behind their old way of doing things. Everyone was ready and eager to change. Okay, you can stop laughing now. That didn't happen. People complained and fought and kicked and screamed about having to change. It wasn't the way things were done. People weren't happy with these changes because they lost control. They thought they knew how to do things already, and they didn't need somebody else telling them how to do it from another perspective. But how did they really get people to adopt it? Because change had to happen. Well, they tied it to money, is what it came down to. You had to show proof as an organization that you had adopted or implemented the new National Incident Management System to receive your grant funding for terrorism preparedness. That was a big motivator back then, and a lot of organizations overcame their resistance to change because they needed the resources to accomplish what they were setting out to do. And it also helped at that time that we were facing new threats, not just terrorism, but the anthrax domestic terrorism situations, and particularly relevant right now, we were thinking a lot about pandemic influenza. So a lot of motivation to change, still barriers. It didn't happen easily. But if you think that getting a doctor and a nurse to communicate together effectively is the worst that you might have to face, look at those pictures on the right-hand side. Try getting the fire chief and the police chief and the director of the local health department to form a unified command for an incident. Before this, many of them had never even spoken to one another and had no idea that they needed to be partners, much less that they would have to be standing next to each other during a disaster someday. So Chris talked a little bit about my background, but this is what I did. I joined the emergency management field after September 11th, and my job was basically helping organizations navigate these new plans and expectations and hazards, all with the goal of building strong relationships and improving teamwork. Back then, if you had asked me what I did every day, my answer would have been that I served basically as a translator. I was helping different organizations learn to speak new languages, each other's jargon, understanding capabilities and limitations, and forging new mental models of teamwork. Getting people together, getting them on the same page, helping them understand each other. You had rural fire departments now talking about anthrax and avian influenza. Paramedics and SWAT teams were learning to work together to rescue victims of mass shootings. Health departments were learning how to not just be a part of the team, but to lead the team. At the same time, police and fire were learning how and when not to assume leadership. All of that happening in the last 15 to 20 years. And so, similar, I think many of us in healthcare and many of us in the TeamSTEPPS community have seen this slide and seen this timeline. But on the healthcare side, the parallels were pretty interesting. That the Institute of Medicine report to Err is Human, recognizing that we had to do something differently. We're harming people. We're killing people with these medical errors. And the foundation of the TeamSTEPPS program and the emphasis on teamwork and working together to create a safety culture to prevent these errors from occurring. It's an interesting parallel to think that at the same time we were focusing on teamwork in healthcare, we were also focusing on teamwork in incident management. And so my thoughts about TeamSTEPPS and incident management from the start have been, these are complementary strategies for safety and for team effectiveness. I would say that many people in healthcare and in public health, when they started learning about the incident command system, were shocked. It just did not feel like a step forward in the right direction. Moving to a command and control structure seemed to negate the benefits of collaboration and new ideas and the reduction of hierarchy in advancing science and new knowledge. And so people were pretty resistant. And I think anybody who was new to incident command at that time remembers sitting down and trying to figure out who goes in each of these little boxes in this org chart. It took forever to try to map everybody to their new disaster roles. Part of it, we weren't really approaching it the right way, but people thought it was just a glorified org chart or only useful in big disasters. And so we were a little reluctant in healthcare and in public health to really buy in. But when you stop to think about what an incident command system is designed to achieve, it offers some clear advantages for incident management. First off, it's flexible, and it's meant to adapt for routine or planned events of any size or type, any disaster, by establishing a clear chain of command. It's built to provide logistical and administrative support to operational personnel. We're not just sending people off into the field and having them fend for themselves. We're actually building a support structure into our incident command to help them get the resources and the planning support that they need. It ensures key functions are covered. It eliminates duplication. It provides structure and standardization. It provides role clarity and common terminology. All of these things allow teams to come together quickly and immediately begin to make an impact. That being said, once we have brought these teams together and they're functioning together, TeamSTEPPS provides the teachable, learnable skills that people need to use in their teams to successfully execute on their mission. Both combine to create a safety net for the mistakes and errors that occur in stressful, rapidly changing events. So adding TeamSTEPPS tools to the National Incident Management System ensures that even newly assembled teams will have tools and common terminology to support effective teamwork and communication. Similarly, learning about standard teamwork practices within the National Incident Management System can help us in healthcare identify ways to enhance our healthcare teamwork practices that have already been implemented. So we'll take a quick look at what the NIMS principles and components are. There's doctrine behind this. There's decades and decades of work have gone into this concept and this framework that we're working within. And the lessons from Katrina really only push that forward even further. The systems and practices we needed to rapidly adapt and expand just weren't there. It stopped being just a terrorism problem. NIMS adoption in earnest really took us recognizing that it was more than one type of disaster that we had to be prepared for. At the heart of any incident, the priorities include saving lives, stabilizing the incident, and protecting property and the environment. That's standard. That is always the set of incident objectives that we're trying to achieve when there's a disaster. And the idea, the principles up there at the top, flexibility, standardization, and unity of effort, we talked a lot about those already, but it has to be adaptable and flexible for any situation. We can't have a different plan and a different way of responding to hurricanes versus tornadoes versus terrorism. It just doesn't work because people don't know what to do. So creating a system that can adapt to any of those types of disasters and needs is really important. And it's also scalable. Remember, I was mentioning that people would sit down and take all this time to fill out those boxes and map people to their roles. But really what you do is you only add positions when they're needed to maintain span of control and to keep your incident under control. And so you only use the parts that you think are necessary. You don't have to build it all out. You don't have to fill all the boxes. And so as people have started to recognize that, it actually is really helpful to have a consistent framework and understanding of how you add to an incident as you need personnel and resources rather than starting from scratch. A really big and important premise behind all of this national incident management system is that when we talk about disasters, all disasters are local. They happen to a place, they happen to a community. And so the idea is that that's where we build from. It's not directed or managed at the federal level. It's each location, each incident, each community is managing its own response. And we build and we support and we coordinate on top of that. But ultimately, the incident begins and ends with the local response. Again, talking about standardization, people know what these branches and these functions within incident management are, define standard practices that allow people to work together more effectively and foster cohesion. And it also includes its own common terminology to help people understand how to use this system. So you can take a firefighter from the East Coast and a firefighter from the West Coast and bring them together, and they're going to know how to be a team. And finally, I think the most important thing that we in healthcare can take from the NIMS principles is unity of effort. It's the idea that we're coordinating activities among various organizations to achieve common objectives. We're all in agreement on what needs to be done, and we're all willing to work towards that goal together. So it enables organizations with specific jurisdictional responsibilities to support each other, but maintaining their own authorities, but we're all under the same tent. We're all working together. We're all harnessing our resources and moving in the same direction. These principles within NIMS are applied in 3 broad components, and I'll talk briefly about each of those. The NIMS management characteristics that underpin all of these, I've underlined a few of them here because I think they're especially relevant when we talk about TeamSTEPPS, but these are the foundational elements within this org structure that we've created within this incident command system, and there are lots of commonalities. So looking there at the establishment and transfer of command, that's a handoff. You're transferring information and accountability to the person that's assuming responsibility for that task. And so there's a briefing that captures that essential information for continuing safe and effective operations and letting people know about that transfer. We know how to do that in healthcare. We know how to do that in incident management. It's the same principle of handoffs. Similarly, information and intelligence management down at the bottom right includes identifying essential elements of information, sometimes referred to as EEI. It's the idea that we need to know what information we need to make good decisions. And everybody needs to know what information they are responsible for contributing, and everybody needs access to information for decision-making in real time. And so the idea of TeamSTEPPS with situation monitoring, leading to situational awareness and a shared mental model, using call-outs to raise attention to new information and changing circumstances to achieve that shared mental model across individual members of the team, across teams, across organizations. You can start to see the parallels between these two systems. One of the core elements of resource management in disasters is the idea that you need to have a common language because we're talking about mutual aid. If you remember mentioning that in a disaster, you don't have all the resources and capabilities that you need. You are asking for help, that shared responsibility for getting things done across jurisdictional lines. Mutual aid is a huge part of emergency management and emergency response. It's not as common in the same way in healthcare or in local health departments. And so it's an interesting thought process to imagine if I were to ask for help from a neighboring organization, would that person or that team be able to integrate themselves quickly and effectively into my environment? Could we send our nurses or our physicians together to achieve a goal? How much work would we have to do to get them ready to be able to work together? Thinking about that standardization. Some of the examples that I've experienced in this when resource management didn't go exactly as planned, I was doing an exercise out in western North Carolina where we had more than 500 people simulating a huge disaster in that community. We had helicopters practicing their takeoffs and landings. We had a simulated bomb. We had a white powder scare. We had, you name it, it was happening on that day to provide some opportunities for practice and learning. And in the after-action discussion following that exercise and what we call hot washes, the hazmat team, the hazardous materials team, spoke up and said, it took us a lot longer to do our job because we didn't have a key piece of equipment that we needed. Had we had that piece of equipment, we could have gotten you answers a lot sooner. Our response would have been a lot faster. And from across the room, you hear this voice speak up and said, we have that equipment in our trailer. And everybody turned to look. It was the state's bomb squad. They had this highly technical piece of equipment the whole time in the same parking lot of this high school where we were doing this drill, but nobody thought to ask the bomb squad what their capabilities were or what equipment they came with. And so it was a really important learning lesson that if we don't know each other beforehand and we don't understand our capabilities and we're not communicating with one another during an incident, we're overlooking opportunities to perform better. And that's what incident management is all about, using the capabilities you have and the resources at hand to their best and most applicable mission. Thinking about that in terms, I'll just go back for a moment, thinking about that in terms of COVID, thinking about personal protective equipment. If everyone asks for N95s, we'll run out quickly, right? And we're experiencing that when people talk about masks, they talk about N95s. But what we're learning is that not everyone needs an N95 because it depends on the application and the use and where that person is going to be and the risks they're facing. So in terms of resource management, if we ask for masks and explain what they're going to be needed for, we might be able to find something that's appropriate for that mission and not use the N95s where they're not needed and save those resources for the people that need them most. That's another principle in resource management is ask based on the need, not based on the name or the type or your preferred piece of equipment. Let the folks in resource management and logistics source that for you in the best possible way. So command and coordination is really at the heart of all of this, and we'll touch on this briefly, but the idea of unified command is pretty revolutionary. It's all of these different organizations and disciplines and jurisdictions coming together and pooling their resources and their personnel to create a unified response. How often do we stay within the boundaries of our own organizations? But in incident management, we're learning how to break those jurisdictional boundaries and finding new ways to work together. The establishment of transfer of command, we talked about that already, but the first person on the scene of an incident becomes the incident commander by default. If I show up at a car accident, I'm the first person on the scene, I'm the incident commander. My job is to establish command and get the resources needed to help me in my response based on my assessment of that situation. But when somebody shows up at the scene who is more senior, more experienced, more qualified to take command, I relinquish command. I give that command over using the handoff we talked about before. And it's about expertise and capability, not about rank, not about jurisdiction, not about seniority. In a lot of incidents now, you'll see that the fire chief and the police chief are not in charge. They're there to support, but they're not assuming command. They're letting their most qualified, most experienced leaders take command of that incident. And so it's just an interesting thing to see taking place because that was not how things were done before September 11th. The most senior person on the scene would assume command, whether they were the right person or not. And you actually, at times, had people fighting over who got to be the incident commander. Is it going to be police because there was the commission of a crime, or is it going to be fire because there's clearly fire emitting from this structure? And they would fight over whose incident it was. Or there would be two command posts, and the fire department would be managing their operations, and the police department would be managing their operations at the side. So a lot has changed. We still have a long way to go, but thinking about ways that we can reduce those barriers between teams and align ourselves, management by objectives, getting on the same page, and then having a clear chain of command and unity of command. How many of us have multiple bosses or competing interests, and we're not sure which will take priority during an incident? Well, the incident command system has a rule about that every single person in that response organization has only one supervisor. You always know where to go for help, support, questions, authority, and there's a clear chain of command all the way up to the incident commander or the unified command so that we're all working in harmony together. There's no question about, do I follow supervisor A or B? We're all on the same page. And once again, when we talk about command and coordination, we talked earlier about the idea that it's not about controlling the incident. It's about leading the team. And this is where I think it's very important for us to learn the lessons from TeamSTEPPS, that this is about leading teams to achieve our objectives. It's not about having all the answers, making all the decisions. That's not what leaders do in this system. They create a system by which people can achieve the mission and the objectives and apply the best strategies and tactics to solve the problem. It's not the incident commander standing at the scene of the incident pointing and saying, you do this and you do that. We learned pretty early on that doesn't work when it comes to these complex incidents. It's best to let it be a team effort and let the incident commander and the command staff think strategically and look ahead and anticipate and gather resources that are going to be needed as this disaster continues into multiple operational periods. And that's where the planning P comes in. For those of us in emergency management and incident management, this is a pretty common thing. For anybody who's not, is like, why are you talking about the letter P? Doesn't make any sense to me. But if you think about this in terms of a process or a routine that you follow during incidents, it's a very prescribed way of solving the problem of what are we dealing with, what are we trying to achieve, how are we going to achieve it, what resources are needed to do that, and then at the end, once we've implemented that, what worked and what didn't work, and what do we need to adjust for tomorrow, for 2 days from now? Are we making progress towards goal or not? Do we need to change and adapt? And this is a very structured way in any incident of getting everyone on the same page. And so there are 6 general questions that I would challenge you to think about if you wanted to use this planning P approach to any sort of problem or challenge that you're tackling. And if you can use in the chat box, offer up some ideas on how you've approached these or any questions you might have about them. But I lied. There are 5 questions that I'm going to pose to you in terms of identifying the overall goal of the response and the incident objectives. How often do you work collaboratively with other leaders to clearly define the mission before you start? To actually sit down together or to communicate with one another and to agree on the objectives and what you're trying to accomplish. The second question is, do you ever sit down and think about the rhythm or the routine for how you're going to conduct teamwork? When will briefings and huddles take place in this process? When are we going to exchange information with one another? How are we going to align all the different elements of our team within this schedule so that we're all on the same page? We all start together and we all end together. The third question is, what is the operational period for this activity? I think in healthcare, we tend to think about 24 hours, at least in terms of hospitals and hospitalization, as we think in terms of nights in the hospital or admissions. But I think most of us would recognize that sometimes we can't just establish a plan once and walk away. We need to recognize that there will be multiple times during that hospitalization or during that day when we're going to have to revisit our plan, to huddle and continuously reflect and refine our plans. So the thought of being deliberate about how frequently do we need to check in on this plan and revise and move forward. This is one that we always take for granted in any incident management, healthcare, any organization. But have we taken the time to clearly define roles before we start? We use a lot of shorthand and say, oh, well, we've got the nurse, or we've got the doctor, we've got the fire department. But do people know who to report to, where and when they're going to get information, and exactly what their what their tasks are within that role and what the tasks of their teammates will be. I think if we don't take enough time to go through that, we're going to miss out, and people are going to be confused in their response. And then finally, do we ever stop to identify the essential elements of information that we need from others to complete our jobs effectively? Do we ever write it down? Do we ever share that with others, with the people that we're working with, so they know what's important to us, so that they know when we need it and why we need it? So that's just a little bit of thought about the planning P and how it relates to our work. And the last section of the NIMS components is communication and information management. As in any industry involving people, communication is everything. Miscommunication leads to errors. We need to do all that we can to keep people on the same page. And in emergency management, we talk a lot about situational awareness and the common operating picture. That's our way of saying the TeamSTEPPS shared mental model. There's a process by which you gather information, you validate it, you conduct analysis on it so it becomes useful. It's not just information, but it's actually intelligence and things that need to be acted upon, and it needs to be shared, and it needs to be continuously updated. ICS uses a lot of standardized forms and briefings, so everyone knows what type of information to be gathering, where to look for new information when it's been shared, and then using common terminology and plain language whenever possible to overcome those barriers to effective communication and teamwork. So ultimately, how does this all relate back to TeamSTEPPS? Thankfully, I would say that both healthcare and incident management organizations are just absolutely fixated on organizational learning. And that's good. That's how we're improving. That's how we're changing the culture. And it breaks itself down into these two components. We're either learning in the moment. We have to feel psychologically safe to provide feedback to our teammates, to speak up when we see things that aren't right or when we have questions, having huddles to adjust and problem solve, and then monitoring our progress towards goal and making adjustments as we need to get to where we're trying to go. But then there's also this idea of continuous improvement after the event. Team debriefings are a core part of TeamSTEPPS. Everyone knows that. But we also know that in incident management, you don't have an incident or a disaster that you don't talk about and you don't learn from. We do, unfortunately, sometimes have lessons observed and not learned because we don't actually do anything about it, but we always talk about the incident afterwards and try to understand what worked and what didn't work and how do we need to improve our plans for next time, because we don't get many disasters and incidents to learn from. You don't get a hurricane every week. And so when you have an exercise or a simulation, you need to learn from those because you can't try new things very effectively when it's the real deal. And I think we share that in common with healthcare. And so ultimately, supporting incident management with TeamSTEPPS tools, it's really about practicing closed-loop communication to prevent those miscommunications that are so common under stressful conditions, building in teamwork tools and events into your incident management workflows, specifying when you're going to exchange information, when you're going to regroup and meet with one another, using standardized forms and checklists whenever possible so people don't have to think about how to organize their thoughts or come up with new ways of sharing information in the moment. And the big one I would highly recommend is conducting just-in-time training for personnel that are being brought together as teams for the first time or being given a new assignment or a new mission, because people need to understand not just the technical part of their task, but also the teamwork elements of their tasks. And then it's up to all of us as designated and situational leaders to set the example for a safety culture in normal operations and in incident response. Because ultimately, welcome to the new normal. This is what incident management has become in the United States. It's no longer these isolated small-scale incidents. We are facing bigger, deadlier, more catastrophic damage than we've ever seen before. These all are since 2013. Not even 10 years ago, we've had all of these catastrophes, these disasters, and now we're dealing with COVID. So we need to deal with more complexity, more uncertainty, more partnerships than we've ever done before. And so part of that, FEMA has this idea, it came from Craig Fugate, who was the FEMA administrator at the time, but this idea of a whole community approach. We have to shift our thinking. We don't have victims of disasters anymore. We have survivors. And those survivors are capable they've always been the people that were the first responders. When a tornado goes through, it's the neighbors helping their neighbors. It's the people in the community who are present and who have the ability to support each other. That's the first response. And then the government and additional resources layer in on top of that. But we can't ignore the fact that people are capable of taking care of themselves and each other in ways that we sometimes discount. And so now emergency management is all about building partnerships and recognizing capabilities and broadening the definition of a team beyond anything we could have predicted 10 to 15 years ago. And so I would challenge you to think about this in terms of patients and families. In TeamSTEPPS, we talk a lot about patient-centered care, but how often do we kind of view them as victims and not as active participants who are fully capable of helping each other and helping themselves with support and with resources that we offer them? They're not helpless. They're survivors. And so we should be thinking about that in the same way with our patients and families. And for those of you who have heard of the Waffle House Index, that's the same guy. So he's pretty smart. I'll offer up this example of what I thought was a phenomenal whole community approach, the cave rescue in Thailand of the 13 soccer team boys who were trapped for weeks, and thinking about what that international effort looked like and how they came together as a team and how effective that response was and how organized and disciplined and structured, despite the fact that nobody had any idea what they were going to do to get these boys out. Even the rescue diver who came up with the plan to sedate the children, I saw an interview with him, and he said he had zero faith that his plan would work. But they had no other options, and they had to try. And so you think about all the work that went into that, it's pretty astonishing. And you think about people volunteering to do laundry for the rescue workers and having their crops flooded. And it's just phenomenal what the community did and the international community did to support that response. And so here we find ourselves in a similar challenge, but it's a global challenge with COVID. What is our whole community response shaping up to be? No organization has all the answers or any answers. And so we all have to work together in the broadest possible definition of team that I can imagine. And in some of these photos, you see the ways that the community is stepping up and becoming survivors and not victims. All the 3D printing of face shields, the distilleries that have switched over to make hand sanitizer instead of liquor, supporting healthcare workers by donating personal protective equipment and meals and offering discounts and doing everything we can to support our heroes. But you look at that picture down at the bottom right, how do we even begin to understand the magnitude of what we're facing and share information and lessons learned? And then at the top, flattening the curve, getting every person involved and doing their part for our response. That's our challenge with COVID, and that's our challenge in this incident. So my final thoughts as we wrap this up 5 minutes later than I had hoped, but I would just challenge you to think about it in this way, that whenever a team comes together to achieve a shared goal, there will always be the need for effective teamwork and communication. So wherever we can learn those lessons, whatever we can borrow or adapt or use from other disciplines, lessons that others have learned, it's on us to apply them to our own situation. But we can also do the same and offer TeamSTEPPS to our partners who may not understand the teachable, learnable skills that make teams effective. So let's figure out how to share those tools and apply them to our current situation so that we can all get through this together. And with that, I'll turn it back over to Chris for questions and answers.
Erin, thank you so much. That was incredibly timely and very interesting, and it's phenomenal to see those connections between what we're doing in healthcare already and what's going on in incident management. There were some comments as we went along about how so much of this reminded people of high reliability organization principles too, and so there's a lot of really great connections there I think people were able to make.
Great.
So just some questions. We got a lot of great questions coming in. I think that there's a couple of different strands here of questions. One is along time and about the resource of time in, how do we get people to really get into the types of practicing that you were talking about that are, to people to think, well, this is hard to carve out time to do maybe simulations of normal surgery events or different inpatient or outpatient events? How do we simulate something large, some sort of large thing, like simulate what's happened with dealing with the pandemic? How do we carve out time to, decide on that shared language that's so important and to really engage folks with understanding how we're going to use that shared language? So what are some of your recommendations along that?
I have a few thoughts on that, and I would say that the one that immediately popped to mind is this is all just one huge PDSA cycle. We will not have all of this figured out quickly. We won't have any of the answers immediately, and so we just have to try and commit to a process of trial and error and learning from our mistakes and from our successes and applying them to the next day's practice. We just have to take it one day at a time here because the incident is already upon us.
Right.
The other element I would say to that is I think in TeamSTEPPS and also in incident management, we've proven time and time again that going slow is the ultimate way to go fast. If you can get yourself organized, if you can take the time up front to agree on things and to decide how you want to proceed, it feels like you're wasting time, but you get that time back in spades. And you don't lose as much energy in the chaos and the confusion and the conflict that results when you're not on the same page. And so just using those principles, I think, of trial and error and taking the time up front are both really important right now.
Those are great lessons. I'm thinking, obviously, healthcare workers and first responders, folks that would be involved in, they have done these types of modeling out and practicing and thinking through things as a team when they're thinking about disasters or some sort of mass casualty event. But how do you bring new groups into that team kind of on the fly? And what I'm thinking about here, just off the top of my head, is I don't think anybody would have thought of, let's say, the food delivery industry as being part of a disaster response, or other people that we're seeing as essential now that we wouldn't have if you were thinking about dealing with a mass casualty like a shooting or something like a hurricane or other events. So how do you bring people in on the fly?
The biggest thing that we've learned in past incidents is that when you discover that somebody needs to be a part of the team, what they need is access to the same information that you have. They need to understand their mission. They need to understand where they fit in the response and what resources they bring to the table and how they're needed. And I think sometimes we hold on to information a little longer than we need to, or we think that we only need to give a little bit of information and people are going to get it. But it really is all about giving everyone access to the same information and being transparent and letting people understand where they fit and where we know things and where we don't know things. But if we allow people to use their creativity and to solve their problems, we have a food delivery problem. Let the food delivery people help us solve it. Give them the assignment and work with them on the conditions and the resources they have available. It's amazing what people are coming up with right now when they're given the task of being creative and finding new ways to do things. But if we sit in a command center somewhere and think that we have all the answers and we're going to solve it ourselves, that's where we run into problems. It really does require letting and bringing people to the table.
That's a deference to expertise, then, for sure, that we would talk about in high reliability. Yeah. The last thing I'm going to ask, there's a lot of questions around when and how you debrief in this. And I know we're up against the clock here, but I'm assuming the answer is that you continuously debrief throughout the course of this, and you're not waiting until the end of an event to do that. But how would you answer that?
I think there's always the two tracks. One is learning in the moment when we've done something and we want to remember it or we want to capture it or we want to adapt because of it. That learning on the fly is really important, and we need to take the time, take the last 5 minutes of a meeting or, at the end of the day, regroup with people and say, what did we do today that we can apply to tomorrow? But I think it's also important that when it's an extended event like this, we need to be thinking ahead and saying we need to schedule time to think about the past and to think about the future, because it's all happening so fast. If we don't take time to pause and be deliberate and reflect on everything we've done up until this point and reassess and anticipate what we think is coming next, we're going to lose the bigger picture. And you have to maintain the immediate present picture in your mind at the same time that you're thinking big picture, and keep those two things flowing as best as you can until you've worked your way out of the incident.
Thanks, Erin. So we have a lot more questions, and I think there's a lot of conversation that people want to have. So when we send out our copy of the recording of this to everybody that was registered for this webinar, please look there for instructions about how we could get your questions unanswered, or get them answered, get your unanswered questions answered, and also how we can really continue this conversation. We want people to be able to continue this conversation. So everyone look for that very soon. In the meantime, you'll receive an email with an evaluation link shortly as well. We really love your feedback. We value it. We look at it on a monthly basis, so take a moment to fill it out. And also don't forget to create a Duke OneLink account if you've not done so to get your CE credit. And then once you're done with that, text the code TARWOR to the number you see on your screen right now within 24 hours of right now to receive credit for this webinar. But you'll not receive a certificate, but you will receive continuing education credit. With that, I'd like to thank everybody for joining us today. Appreciate you taking your time out of your busy day, wherever that may be, working in the field right now, or sheltering in place at home and dealing with your kids' education, or both. So thank you all so very much for taking the time today. Erin, thank you so much for bringing this really timely and pertinent information to the community, and we look forward to seeing you all on Mighty Networks.
Thank you, ladies and gentlemen. This concludes today's presentation. You may now disconnect.